All right, so we'll get started. I have no disclosures, financial or otherwise. And I want to give credit where credit is due. There are two primary sources that I'm using, among others, but I'm really grateful for these sources. There's the Ames Center at the University of Washington, which is a group of faculty, staff, and consultants that does research on the implementation of collaborative care. And also the American Psychiatric Association's training on collaborative care, which I would recommend to anybody and everybody. And I've asked permission from them to use some of their slides in order to present this presentation today. So let me give you some background information on integrated care. So there was a study done in 2005 nationally that found that of all the people in the United States that had a diagnosable mental health disorder or substance use disorder, only 4 in 10 received any kind of treatment. About 1 in 10 saw a psychiatrist, 2 in 10 saw any mental health care provider, and then another 2 in 10 saw a primary care provider. That leaves another 60% of people who needed treatment that didn't get it. So how do we close this gap between those who have care and those who still need care and aren't reached by a mental health specialist today? Is it better referrals? Do we need more providers, or do the providers that exist just need to work harder? We're going to sort of talk through these and why maybe that's not the answer. So it turns out that studies show that half of the patients who are referred to a mental health specialist, like a psychiatrist, from a primary care provider just don't follow through. So you have half of those referrals just following through. Half of them do receive treatment, but of those half that do receive treatment, they're authorized for up to 12 visits. Usually they receive about 2 before they fall out of services. And so referring just isn't a good option, or at least not good enough for some of the more severe cases. And looking at another way, there just aren't enough specialists to refer to. So this represents a map of each county with estimates of mental health professional shortages in the United States. The darker gray areas represent those with the greatest unmet need. So it was found that 1 in 5 counties in the United States had an unmet need for non-prescribers for mental health treatments. And almost 96% of counties had an unmet need for prescribers. So that's the vast majority of counties in the United States. And this need was much greater in rural areas compared to urban and other areas. And yet another way to look at it is, why can't those providers just work harder to see more people? So if you consider that a provider works on average 35 hours a week of direct patient care, the other 5 hours might be admin time or breaks or other things. So there's 35 hours a week where a practitioner sees a patient. Ideally, they're trying to see a patient for 50 minutes to get an adequate assessment. But if you take the number of providers times that 35 hours a week, and then you divide it by the actual number of people in those areas that need mental health care. So if those providers that existed were trying to see every single person that needed mental health care, in urban areas, each patient would only be allotted 6 minutes of time, of a psychiatrist's time. In rural areas where providers are in greater shortage, each patient that needed to be seen would be allotted 1.5 minutes of that psychiatrist's time. So you can see that that is not feasible. So better referrals, that's not necessarily feasible. More providers, well, we know we need more providers, but that's a long-term problem. And working harder, it just doesn't add up with the number of patients that need to be seen. So spoiler alert, working smarter is probably the best option, which is what integrated care is. And there's a lot of different models of integrated care. Some were evidence-based, others just evolved from clinical necessity. We're going to be talking about some of these different models in the slides to come. So traditional consultation, that's what you generally think of, where a primary care doctor refers someone to a behavioral health specialist. But there are some significant limitations to this. There's never going to be enough psychiatrists to refer all the patients to. There's limited feedback, so primary care doctors experience psychiatric consultation as a black box where they might get a note back, but there's very limited communication directly. It's very expensive. Mental health referrals require full intakes, which leaves little time and energy for follow-up or curbside consultation. And it's sort of a one-pass model, which works best for people with acute issues who don't need follow-up, because as we saw on the slide previously, generally 1 or 2 visits is the average that most people get. A different model is co-location. This is where a mental health provider like a psychiatrist or a psychologist is actually embedded in the clinic. They don't necessarily have a different model of seeing patients, but they're there so that if the primary care doctor needs to curbside, they at least have better communication and are using the same EMR. The advantages are that the psychiatrist is there, obviously. There's opportunity for interaction in curbsides. There's better communication, often the same chart, and coordination with transfers back to primary care just run more smoothly. But the limitations are that it's still an access problem. The psychiatrist spots fill up quickly. There's a lot of no-shows and very little room for follow-up. There's limited ability to make sure those recommendations are carried out, and it's just not available in many settings to have a psychiatrist for a primary care office to be embedded. Let's see, so behavioral health consultant or BHC model is another one that shows a lot of promise, but actually the evidence doesn't bear it out very well. So it has a behavioral health provider, typically a psychologist that's embedded in the primary care clinic, and provides rapid access to behavioral health assessments, interventions, and addresses a wide range of mental health and substance use problems. But it is limited. Usually they have 1 to 3 visits with that behavioral health specialist before they need to refer back to primary care, which is just not enough time to really address severe mental health concerns. And there's actually limited evidence that it's more effective than typical primary care for patients. So now I'm going to spend the majority of the time talking about the collaborative care model. It has been developed to address mental health concerns on a population scale. So there's a whole caseload of patients that's followed by a behavioral health provider and a primary care provider who are co-located in the same setting. But the behavioral health provider right here is typically mid-level, such as like a social worker, counselor, psychologist, or even an RN. And there's a psychiatric consultant that's on this panel that usually only sees patients indirectly, but they are available to see a small percentage of patients directly. And of course, the PCP is key to this model as well. And all 3 of these, or 3 or more of these specialists are working together to provide that patient-centered care. So the collaborative care model has a lot of pros. There's better access. PCPs get their input on their patients' problems within days to weeks versus months with the traditional model. It focuses in-person visits on the most challenging patients. So like I said, the psychiatric consultant usually reviews cases indirectly and then saves their clinical time, their direct clinical time for the most severe patients. There's regular communication. Usually the psychiatrist has weekly meetings with the BHP and care manager, and they review all patients who aren't improving and make treatment recommendations based on that. There's, instead of just 3 to 4 patients that can be seen in a half day, it's 10 to 20 patients that can be reviewed and treatment recommendations provided in a half day, which is a huge improvement. And they get to shape the treatment over time. So rather than just having 1 hour-long consultation, there's multiple brief consultations over the course of months, and it allows the opportunity to correct the course if the patients aren't improving. So why should we practice collaborative care if that's not enough reasons? Well, there's 5 main reasons. It's evidence-based, it shows better medical outcomes, it helps with challenging patient cases, shows faster improvement, and as a team model. And we'll talk through some of these. So you might have heard of the impact study. It was done originally in 2006, updated in 2014, where we had 1,800 patients from 18 different primary care clinics in 5 different states that were randomly assigned to 2 different groups, a collaborative care model versus usual care. And the usual care arm just allowed primary care providers to continue any mental health care that they would typically provide, which was either prescribing medications themselves or referring to mental health providers. And in the collaborative care arm, we sort of talked about that team approach with a panel of reviewing professionals. It was found that out of those 8 participating healthcare organizations, all of them showed much higher levels of improvement in depressive symptoms compared to usual care. You got 50% or greater improvement of depression at 12 months, whereas those in usual care, it was about 10 to 20% of patients that were improving. So a large difference. It was also found that it could be helpful for a variety of patient populations, and that different ethnic groups were improving at the same rate, where it was at least double the impact for the collaborative care model as compared to the usual care model. It was also found that healthcare costs were significantly reduced when the patients were followed for 4 years after the original study. They found that every dollar that was spent on collaborative care saw $6 in savings in total healthcare costs. There was actually another study done by the American Psychiatric Association, who hired the Milliman firm, which I'm not actually familiar with, but they actually examined the databases for Medicaid, Medicare, and commercial insurance claims to compare costs of those in the collaborative care model versus those in usual care, and found that as much as $26 to $48 billion could be saved every year if mental health disorders were effectively treated with integrated behavioral health care. So some pretty significant findings across the board. There was also another study done with the team care model, which was a collaborative care model in Washington led by Dr. Wayne Caton, who not only examined the mental health outcomes, but also the physical health outcomes of people in the collaborative care model. So same model, but that just monitored other criteria as far as depression, blood pressure, and hyperlipidemia. And this was another randomized controlled trial that found that patients who were assigned to the collaborative care arm of the trial had much better health outcomes across the board compared to those in care as usual. They had better control of their diabetes, their blood pressure, and their lipids, and also found that there was a cost savings of up to $1,100 per patient in the collaborative care model, which is pretty amazing. And since that original impact trial, there have been over 80 randomized controlled trials that have shown that the collaborative care model is consistently more effective than usual care. And not only that, but it's been studied for additional diagnoses now besides depression, and has been found to be equally effective in anxiety and PTSD. And there's emerging evidence for other disorders such as ADHD, substance use disorders, and others. So let's talk a little bit about how collaborative care is actually practiced. There's 5 main principles of collaborative care. It's population-based, it's measurement-based, treatment to target, patient-centered, evidence-based, and accountable. And we'll talk through each of these as well. So what does it mean to be population-based? It means that we're actually going to make sure that we have an identified population of patients that needs help, and that we make a comprehensive list of all the patients who are currently actively involved in treatment. So this is a picture of a registry. This is what's typically used in the collaborative care model. You might have seen things similar to this for other chronic diseases like diabetes, where a clinic tracks each patient and their markers over time to make sure there's improvement. You can see that over here, there's the date of their most recent visits. So you can see if anybody is falling off or falling out of care. It's got their most recent PHQ-9 and GAD-7 scores, so you can see if they are actually making improvement. And this is actually the last follow-up contact scores. So in addition to targeting an entire population as opposed to patients on an individual scale, collaborative care also is measurement-based with treatment to target. So what that means is that at the beginning of treatment, you identify a goal. A lot of clinics who are using this for depression, for example, might identify a PHQ-9 score of less than 10 as the treatment target. And so they track that improvement over time. In their case conferences where they meet once a week, they will go over these improvements or lack of improvements and make adjustments in their treatment in order to achieve remission of depression symptoms and meet those goals. So there's treatment to target in an evidence-based way. It is a patient-centered model, and you will always see the patient right in the middle of this team. And so the primary care provider is usually the initial contact, which makes sense, right? They are best known by the patient and usually have a relationship of trust. And that primary care provider is then responsible for engaging them, talking to them about the collaborative care model and starting treatment for them. So they make the original diagnosis, they start treatment with medications, and then that follow-up is achieved by incorporating the other team players here. So the behavioral health professional here also then gets involved, and they're going to be, well, there's actually two different types of models. One is where the behavioral health professional is just one person. The care manager and behavioral health professional are the same person, or they can be two separate people. And so we have one person doing time-limited therapy or counseling, and one person who is also doing additional patient engagement, systematic initial information gathering, tracking treatment over time, supporting the treatment plan, helping the patient stay engaged with the primary care provider. So that's the role of the care manager, and either it can be combined or it can be two separate people doing that. And then we have the psychiatric consultant who, like I said, usually is seeing people more indirectly. They don't even have to be co-located on site. They can be someone that that comes in once a week to do the case conference, to review patients on the registry, or they can be co-located if those resources are available as well. And these are people who are providing that consultation about medication management and additional interventions such as therapy. So the principle of being evidence-based, this is different than the slides that we went over a few minutes ago about all of the studies that have been done that show that collaborative care is in fact evidence-based. This means that we want to use evidence-based treatments. We're not going to do our personal preferences as far as medications and therapeutic interventions. We are going by the most recent, most current evidence about how to treat the diagnosis at hand. And this does not just mean medications, it means behavioral interventions as well. And we come to those conclusions about what to use by team approach, by discussing it as a team. Accountable care just means that we are following up, we are making sure that we are reaching our goals. It's not the kind of thing where we implement a plan and then we don't go back and make sure that we are achieving those goals. So this actually is a graph that was based on a collaborative care program in Washington State. And in the first year, the team went back and looked at their improvement data, and they found that it was taking too long, almost a year, for 50% of the population to have some improvement in their depression symptoms. And so they developed a plan. They said that each care manager needed to discuss with a psychiatric consultant half of the patients that weren't getting better, and that their goal was to have at least 2 contacts per month for each of those that weren't improving to intensify their treatment. And then they made their pay sort of based on whether or not they were achieving those. I'm not advocating for any cuts in payment based on achievement of goals per se, but the point is that they went back and looked at their their performance, found ways that were concrete that they could improve, and continued to follow up through time. And they found that the median time to depression treatment response was cut in half after they found that plan and implemented it. So those are the 5 basic principles of collaborative care. And I wanted to talk through a little bit more about collaborative care workflow. What does the actual on the ground workflow look like? So the very first step is to identify and engage patients. This pretty much relies on the primary care provider who actually identifies and engages these patients. But the psychiatric consultant can also help if there are barriers about getting patients engaged, trying to identify those and overcome them with a team approach. And in order to identify which patients should be engaged in the collaborative care model, we recommend that the primary care provider actually use these assessment tools, which you're probably familiar with, but maybe get underutilized in a lot of clinical settings. But having a threshold for PHQ-9 scores or GAD-7 scores where patients will then be engaged into the collaborative care is important. And the nice thing about these screening tools is that they're not only widely available, but they're relatively easy to use with a variety of levels of expertise by practitioners. And once it's identified that someone needs to be engaged in collaborative care, then these scores can be added to the registry for future tracking. So now that we have identified and engaged our patients, it is important to establish a diagnosis. A lot of the people on your team may not have extensive history in making psychiatric diagnosis, and that's where the psychiatric consultant comes in and helps to establish what's called a provisional diagnosis, a working diagnosis, while you continue to treat and see a patient. So in the weekly case review meetings, usually the behavioral health professional will be asked to report on the major diagnostic disorder domains like depressive symptoms, bipolar screening, anxiety symptoms, etc. And then you also ask the behavioral health professional to report on past treatments, how patients have responded to them, psychotherapies they've been engaged in, assessments of safety, so that you can get a good idea of what working diagnosis or differential diagnosis you want to consider for the patient. And the nice thing about that is you not only have these screeners filled out by the patients and the assessment of the behavioral health professional, you have also the primary care doctor's original assessments, and you have the psychiatric assessment based on the case review or direct evaluation. So you have multiple sources that are contributing to a provisional diagnosis that has a much better sense of the actual patient than a one-time 1-hour visit. And not only do you have a better base for formulating a diagnosis, but that diagnosis continues to evolve over time. It can require multiple iterations of assessment and intervention and longitudinal observation rather than that one-time observation. So you start with a diagnosis that's your best understanding and adjust it over time. So rather than just having a diagnosis and a treatment plan at one point, you continue to provide the intervention, gather information, exchange information, and adjust accordingly. So another way to look at it is the comparison of traditional consultation, where you get one highly trained specialist for 60 to 90 minutes, variable use of validated behavioral health measures, and often little follow-up. Compare that to a caseload case review, where you get a team perspective, consistent use of validated measures, and systematic follow-up facilitated by the registry. You're just going to get a better diagnosis in that way, and treatment. So even though mostly the psychiatric consultant is seeing people indirectly through case review, about 5 to 7% of patients on average might need direct consultation. And the nice thing about that is that these patients have been talked through, they've been pre-screened by the behavioral health professionals. You go in with a lot more information, and you're able to make a better, more comprehensive, and sometimes quicker assessment. The most common indications for that direct assessment would be diagnostic dilemmas, treatment resistance, education about diagnosis or medications, and complex patients like those who are pregnant or medically complicated. Okay, so now that we have identified, engaged, and established a diagnosis, we move on to initiating treatment. And this is not just a psychiatrist developing this. This is a shared care plan that's developed with the entire team using both psychological and medication targets. I'm sure you've heard of the biopsychosocial model. So this is an important part of collaborative care. We're not only going to be providing treatment recommendations for evidence-based medications, but also evidence-based psychotherapeutic interventions and social support that allows that patient to continue to be engaged. It's important that we not only develop this as a psychiatrist, but also to develop it with the entire team, to review all the evidence-based treatments options available and come to an agreement discussing the pros and cons of each option. So this is just a list of non-medication strategies that are evidence-based for each of these disorders. So you might find a psychiatrist not only recommending Prozac, but also recommending behavioral activation, CBT, harm reduction strategies, brief interventions for alcohol. All these are very evidence-based interventions that can be recommended for that biopsychosocial model as opposed to just the medication strategy. So how does the psychiatric consultant then communicate the recommendations to the team? Most of the time, they're not only going to be talking about it in case conference and then relying on those practitioners to implement the recommendations, but they also provide a brief case review note that can become part of the EMR. And so the first part of the note is just a summary of the case that they discussed, including the medical problems, current medications, and patient and provider goals. And this is the second half of the note. It also includes the provisional diagnosis and recommendations that are geared to be useful towards a primary care provider. So you'll notice that there's the number one is not a medication, it is behavioral intervention targeting sleep hygiene. And then when we do talk about antidepressant augmentation, we're giving two different choices. This allows the primary care doctor and the patient flexibility to consider options rather than just having one recommendation. It recommends close contact with the care coordinator and even future options if the original options don't work. So it's really geared towards something that's useful for a primary care doctor and patient to talk about together and to continue working on together without the need for consults beyond what is already scheduled. Okay, so we've initiated treatment and now we're on to the last two steps. And I just want to point out that these two steps are really where we get to the difference between collaborative care versus usual care. I mean, the team approach is great and it's important, but this is where we start to see the tremendous improvements in outcomes by having these last two steps as part of the model. So it's important that the patients routinely brought back to the clinic to be engaged or by telephone in order to assess the behavioral assessment tools, to make sure that if they're not responding to current treatment, that changes are made, and that that if there's anything that needs to be addressed, that's being done in a timely manner where we're not wasting time keeping a patient on a medication or a treatment that's not working for them. So there's two primary phases of collaborative care treatment. The active treatment is the phase usually in the first 3 to 6 months of treatment, where they're having more frequent contact, a minimum of 2 contacts per month, both phone and in-person are appropriate. And this goes on until the patient has achieved greater than or equal to 50% decrease in symptoms or PHQ-9 score under 10, if that is the goal that's been decided upon. And after that initial, hopefully 3 to 6 months, they're transitioned to the monitoring phase, where it's just 1 contact per month, and usually lasts about 3 months to ensure that the patient's mood symptoms are stable. So just to show you a comparison, usual care is generally 3.5 PCP visits per year. And with this, you usually see a 20 to 40% treatment response or improvement at 12 months. With a collaborative care model, you're not only getting those PCP contacts, 3.5 on average per year, you're also getting the behavioral health professional who has an average of 10 contacts per year. And the case reviews with the psychiatric consultant is an average of 2 case reviews per year. And so over the course of 12 months, you can see there's a lot more frequent contact. And studies have shown that there's 50 to 70% treatment response or improvement at 12 months with this model. And what does that hour-long consultation with your behavioral health professional and your PCP look like? So usually the first 5 minutes or so are used for a brief check-in. This is where you talk about systemic questions, big picture questions that either the BHP or the PCP wants answered. And then you identify patients and conduct reviews. So you go through the list of patients that you'll be discussing and why. It's usually the behavioral health professional or case manager who's requesting that this particular patient be reviewed. And it's usually based on whether or not they're improving, the severity of their presentation, if they've disengaged from care, or if they're ready for relapse prevention or referral. And we'll talk more about that last line later. And then at the end of the meeting, you wrap up, you confirm the time for the next consultation hour, and send any educational resources discussed. If the PCP wants to learn more about this or that intervention, then you can talk through some of those things as well. Okay, so we've done follow-up care and treatment to target. Once again, the last step is very important as far as the success of the collaborative care model, which is complete treatment and relapse prevention. And this phase is kind of a new concept to psychiatric consultants. So on average, a patient is in treatment with a psychiatric consultant for around 6 to 10 months, but there's a huge variation among patients as far as how quickly they're able to get better. Some studies show that in the treatment of depression, 50 to 70% of patients need at least one treatment change before they achieve improvement. And that every change in treatment gets approximately 10 to 20% of their patients better. So it's important not to give up too soon if one treatment plan doesn't seem to be effective. And with this diagram, you can see that there's 2 typical outcomes from a collaborative care caseload. Number one is that the patient improves. And the second one is that they don't improve and they need more specialty care. And so they get that referral to the outside psychiatrist, because remember, the psychiatrist that is on our panel is meant to be time limited and to help patients for a short period of time, just to determine whether they're going to get better or whether they need to be referred to a more permanent psychiatrist. All right. If the patient does show improvement and they're ready to be referred back to the primary care panel, excuse me, if they're ready to be referred back to the primary care panel, it's important to create a relapse prevention plan. And so that plan goes over important information like current medications, other effective treatments, personal warning signs, details about how the patient's going to minimize stress from depression and anxiety. It can also include additional information about what to do if the symptoms were to return. And then this plan can be included in the EMR. It can address questions that the PCP might have and provide a plan for the patient about what to do if they do have a relapse. And that may be reintegration into the collaborative care model or referral to a specialty mental health provider. So that's it as far as the actual workflow of collaborative care. And I wanted to mention that there are some examples of integrated care in our area. Number one is the PCMHI program, Primary Care Mental Health Integration Program at the VA. It's present at multiple VAs in our region. The one that sticks out most to me is the one at the Mather VA in Sacramento. It is not fully a collaborative care model. in the sense that I don't believe they use a registry, and if anybody knows, they can correct me. But they do have a co-located psychiatrist and psychologist who are able to curbside and provide answer questions about patients that are currently being seen in primary care, and also receive those referrals from primary care doctors to add to their patient panels. It's been shown to be very effective and very patient-centered. So it's a great model. UC Davis also has a pretty traditional collaborative care model where they do use a registry, and they have psychiatric consultants that go out to their network clinics to provide that. But also there is the Train New Trainers program, which is a one-year fellowship for primary care providers to learn more about mental health treatment, to be able to provide just a higher level of care, given that half of all people who need mental health care are just going to be presenting to their primary care provider. It just offers them some additional expertise. And they've actually done studies that show that this program showed large effects on perceived competency, self-efficacy, and confidence in the treatment of common psychiatric disorders encountered in primary care settings. They have scholarships for this program. If you or anyone that you know who's a primary care provider is interested, please take a look at it. It is available through UC Davis and UC Irvine, among other places. And also I want to mention combined training programs, because that's very near and dear to my heart. There are a limited number in the United States, although this is expanding, and there are new programs that are not shown on this map. The one on the left with the blue stars, these are family medicine and psychiatry programs where they combine the training for both. I graduated from UC Davis, where I did the family medicine and psychiatry program, which is a 5-year program that integrates training throughout the 5 years. And it's not just a dual boarding program. You don't just learn psychiatry and just learn family medicine. They also teach you integrated care, which is so important. And then on the right with the red stars, these are all the internal medicine and psychiatry programs in the United States. Once again, expanding. Some of the programs are not on here, but excellent programs that I hope will continue to expand throughout the nation. Last thing I wanted to mention is that even if you're not in a position to be able to start a collaborative care program in your clinic, you can incorporate principles of collaborative care without having to change your model. And this just includes very basic things like having patient-centered goals, focusing and tracking on a defined population, like using a registry, using measurement-based treatment to target for that population, like behavioral health measures. I can't emphasize enough how important it is to make sure that you are doing the PHQ-2 at the very least for every patient that comes into primary care clinic. And that for those who are on depression treatment, just having those, measuring the PHQ-9 every time they come in to see what the improvement is, or the GAD-7 if they're being treated for anxiety. These are things that are going to improve outcomes regardless of your model. Consistent use of evidence-based treatment rather than just personal preferences as far as medications go, and accountability to measuring outcomes, especially improvement, satisfaction, and cost. Being accountable is always going to improve outcomes in any area of medicine. So these are some of the principles that you can incorporate, even if you're not in a position with your clinic to start a new model. So these are some of my references, and thank you for being present today. Once again, it's a subject I'm very excited about. Are there any questions or comments that anybody had?
Okay, it's a quiet bunch.
I did have a question. Are you aware of any resources for primary care physicians where they can call a psychiatrist and get like a curbside consultation? Because UW does have a program like that, and so does OHSU.
That's a great question. I don't know for our area. I'm actually new to the Butte County area. In Sacramento, I'm not aware of that, but does anybody else on this Zoom call know?
Not off the top of my head. Boy, that sounds like a great service though.
Mm-hmm. I would love to know more about the models in Washington and Oregon. If you have any resources on that, please send them my way.
I will email you. I believe the pediatric access line is called PALS and through the University of Washington, and it's called Opal K in Portland through OHSU.
That sounds awesome. Would love to know more about it. Thank you.
Yeah, you're welcome.
Thank you for your time today.
My pleasure. Thank you for everybody else who spent their time on this today. I appreciate everybody who's here.
Thank you, Dr. Mitchell. It's really inspiring. I'm looking forward to seeing the outcomes of the residency programs.
We are too. We're very excited about it.
Mhm.
All righty. Well, thank you so much, everyone. And we'll be wrapping this call up unless there's any more questions.
Take care, everyone.
Okay.
Mhm.
Bye. All right. Good job, Dr. Mitchell. Oh, she's left already. All right. I'm going to hang up.